I'm going to give it about 2 more minutes. Okay, so I'm going to get started. Um, I am Dr. Holmes. This, of course, is Rockville Internal Medicine Group, and we are very, very happy that you guys have decided to join us. This month is Colorectal Cancer Awareness Month, and so what better way to talk, to kind of celebrate colorectal cancer awareness and get more information than to talk with one of our very own gastroenterologists, Dr. Wu, who is going to be talking with us today. I just want to kind of read the bio that is on our Privia website just to kind of tell you a little bit about her. She is passionate about internal medicine and working closely with her patients across the Rockville area to help them achieve their optimal health. She went to University of Maryland School of Medicine in Baltimore, and she completed her postdoctoral residency training at Johns Hopkins Bayview Center in Baltimore, Maryland. And she specializes in gastroenterology. So she has got a wonderful presentation that she has prepared for us, so I'm very excited. I have all of the questions here, so keep them coming as the presentation goes along, and I will try to save about 15 to 20 minutes at the end of it to kind of give those questions to Dr. Wu and have her answer them, about 20, 25, depending on how many. And then we also may have a special surprise with our nutritionist, our nutritionist, Lori Shell, may also be popping on at about 12:30 to give us some information. So very excited. Dr. Wu, it's all yours.
Thank you, Karia, for sponsoring, and thank you, Jamie and Travis. So let me get started. So I'm Dr. Grace Wu, gastroenterologist. I'm one of the 2 gastroenterologists at Rockville Internal Medicine Group. I'll be talking about colon cancer screening, I should say colorectal cancer screening, since our month, March, is a celebration for colon cancer screening. Let me actually move on to this chart. Okay. This is from American College of Gastroenterology. So I'll be using this chart. It has more pictures, so I think you'll enjoy it more. So in the United States, colorectal cancer is the 3rd most common cancer in both men and women. Of course, lung cancer, breast and prostate cancer is also number 1 and number 2. But colon cancer is the one cancer that you can actually prevent. And that's what we want to talk about. We know that by removing polyps, which are little growth, when they're small, they're benign. But if you remove those during colonoscopy, you can prevent colon cancer. So what are some of the cancers that we screen for? We look for breast cancer, prostate cancer, lung cancer, but it's none of those tests that we do to detect those cancers are preventable. Colon cancer is the only one that we can actually prevent and detect during one study, which is a colonoscopy. Why is colorectal cancer screening important? I think I mentioned this already, that we're not just detecting colon cancer, we're actually preventing colon cancer by doing colonoscopy. Let me move on to the next picture. So this is an anatomy picture where it tells you that colon is actually pretty long. It's about 6 feet. When the terminal ileum, let me see if I can use my arrow. That's the last part of the small bowel that connects to your colon. That's the cecum where the appendix is right here. Ascending, going above the right, transverse across your abdomen, descending sigmoid and rectum. So during colonoscopy, we are evaluating the whole large intestine. Where does colorectal cancer start? So the cancers in colon usually start from a benign growth. So if you look at the chart, at the picture below, a little bump, what we call polyp, can grow. And when they're growing and when they're small, we call that benign lesion. And these are the ones that we can remove during colonoscopy. Even if it is turning into cancer, we pretty much call it high-grade dysplasia. And even if it turns into cancer, as long as it has not invaded the submucosa in the muscularis, stage 1, we can remove that cancer by colonoscopy. Once it spreads, unfortunately, colonoscopy will not be enough. Then you do need surgery to remove the lesion. So about colon polyps, when a polyp is small at the lining of the colon, like we said, they're benign, we call them benign, and we remove them during colonoscopy and we send them to the pathologist. The pathologist can tell us what kind of polyp it is. There are polyps that will never turn into cancer. Those are called hyperplastic polyps, usually found in the rectum. Patients with hyperplastic polyps are considered average risk, so we do not do surveillance more frequently. But if the polyps are adenomatous, the ones that we call premalignant, then your risk of colon cancer goes up higher. So we do surveillance much more frequently, and those are the polyps that we're looking for. These are some pictures of different types of polyps. The types of polyp that we like to see are this ones, the one that look like a lollipop or a mushroom, or you have a stalk. Why? Because we can lasso it, we can snare it and remove it, and these are very easy to remove. When the polyps become bigger, that becomes a challenge, but usually we're pretty good about removing them. That's a polyp. That's also a polyp that looks like it's turning into almost a malignant polyp. This looks benign. And you can have these flat lesions called sessile polyps and also pedunculated polyps, what look like lollipops. Polyps can also be a little tough to see. Do you see these folds? These are normal, called haustra. That's part of a normal colon. Polyp, however, can also be hiding behind the fold. So the question is this the polyp or is it just a prominent fold? This is a scope. It's a very flexible scope. If you retroflex it, look back on itself to take a selfie, then here you go. That little bump that you saw on the way in is actually a much larger polyp. Again, this is something that we can remove during colonoscopy. This is the same thing, but a different lighting. We do have different lighting techniques available with our Olympus scope. So when we look at the polyp, we can see much clearly, is this a benign polyp or premalignant polyp? And that most likely it's going to be an adenomatous polyp. Here we go. These are the lollipop type of mushroom polyps where we like to snare it. And since there's a stalk, we can easily remove it completely and send it to the pathologist. Now, the question is, there's so many other ways of screening for colon cancer. Why colonoscopy and not something else? Again, colonoscopy is the only screening test that we have that you can not only look for polyps, but also remove them during the procedure. And by removing of the polyp, we can prevent almost 90% of the colorectal cancer. Here we go. That's another same picture, and that's the scope going in. By the way, you will be sleeping during the procedure, so you will not feel me or anybody else, any of the GI doctors go around. And the scope, I'm going to use my stethoscope to give you an idea, is sort of like this, very flexible. And it goes all the way around to the cecum, and then we come out. We do put air in, so you will feel some bloating and distension, but once you let that air out, most patients, when they wake up about 20 minutes later, do not even realize that we actually did a colonoscopy. Here, there's more pictures of polyp. And sometimes when they're bigger polyps, we inject a little dye, it's called methylene blue, right underneath the mucosa because it raises the polyp and it allows us to remove it. This may look like a big hole, but this heals on its own without us having to do anything. And the other question is, well, am I going to have any pain when you remove polyp? No. The only time you have pain with the colonoscopy is when we put air in. So when the colon is insufflated and distended, that's when people feel bloating. Any cutting that we do, any cauterization, most patients have no symptoms and the colon just heals on its own. How safe it is it's very, very safe. There is a very small risk of bleeding. That's why we do not want any aspirin or Motrin unless you have to have it for cardiac reasons. So you have to talk with the GI doctors. But the risk of bleeding is very low, very small risk of perforation, 1 in 10,000. The risk is extremely low, knock on wood, haven't had any. But because it is so safe, it's recommended as a screening procedure. So the next question is, well, who is at risk for colon cancer and who should get screened? So colorectal cancer can affect both men and women. 1 in 23 lifetime risk of colon cancer in men and 1 in 25 lifetime risk of colon cancer in women. So we see a little bit more frequently in men, but there's about 5% lifetime risk of colon cancer in both men and women in average risk. In 1990, so recently, we're seeing a lot more colon cancer and rectal cancers than for patients born in 1950. We don't really know why. We think it may be because we're eating unhealthier foods, sedentary lifestyle, etc. So there's been some changes in guidelines, which I'll talk to you in a bit. What are some of the other factors associated with colon cancer? So if there's a family history of colon cancer, your risk of colon cancer goes up a little higher. So remember I said 5% lifetime risk. If you have a first-degree relative that's older than age 50 with colon cancer, your risk goes up 12%. If you have a first-degree relative who had colon cancer at a younger age, less than 50 years, your risk goes up to 20%. And if you have 2 first-degree relatives with colon cancer, your risk goes up to 30%. So definitely some genetic predisposition. We also think that there's some environmental factors. For example, in Asia, the risk of colon cancer is not as high. The risk of stomach cancer is much higher there. So there's a lot of stomach screening going on for stomach cancer. However, for those patients, Asian patients that come and live in America, including me, my risk of colon cancer is same as the Caucasian, so the average American population. So we think that has to do some environmental lifestyle changes, diet that may be associated with increased risk of colon cancer. If you have family history of colon polyps, that also puts you at a little bit higher risk for colon cancer. Smoking also puts you at high risk. Obesity, which we think is contributing increase of colon cancer and rectal cancer that we're seeing. Gallbladder removal. I don't think it's actually the gallbladder surgery that does it, but people who do have gallbladder disease usually are obese, which predisposes you to gallbladder disease and gallstones. Physical inactivity, again, this fits into the obesity inactivity. Any radiation, abdominal radiation, also puts you at a little bit higher risk. And cancer of the uterus and ovaries before age 50. There's certain genetic predisposition that called the Lynch syndrome also puts you at a little bit higher risk with ovarian and other cancers as well. And if you have inflammatory bowel disease, ulcerative colitis or Crohn's colitis, in inflammation in the colon, after 8 to 12 years, depending on how long you've had your colitis and what segment of your colon is involved, you do surveillance colonoscopy because you are at higher risk for colon cancer. An African American race, before the new guidelines, average risk colon cancer started at age 50. Colon cancer screening started at age 50. However, we've always known that in African Americans, younger patients get colon cancer. So we've always started at age 45 for African American race. So what are the symptoms of colorectal cancer? Actually, early colorectal cancer have no symptoms, which is why we do colonoscopy as a screening test. If you do have symptoms, however, and if they are from colon cancer, usually the symptoms you're looking for are blood in the stool. And remember, however, you could also have hemorrhoids too. So not all blood is coming from colon cancer. So don't be alarmed, but they do need to be evaluated. Changes in bowel habits. All of a sudden, you're getting constipated, or you're going from diarrhea, constipation, etc. Changes in size and shape of the stool. Also keep in mind that the size and shape of the stool is also determined on how much fiber, how much hydration, activity. So all that plays a role. So just because you have a change in size and shape, that does not necessarily mean you have colon cancer. But if it persists, then you should have it evaluated. Rectal pain, abdominal pain, unexplained weight loss, and unexplained or new anemia, specifically iron deficiency anemia. So what should you do? What should I do if I don't have any of the symptoms of colorectal cancer? You still need to get screened. In fact, the screening is for asymptomatic patients, for patients who have no symptoms at all. So now we're going to talk about how do you screen. So American College of Gastroenterology breaks it down into one-step and two-step screening. And one step is basically the colonoscopy, where if you do colonoscopy, not only do you detect colon polyps, but you can actually do something about it. You can remove it. So the one-step test would be the colonoscopy. Yeah, I talked about this already. The two-step screening tests are all the other tests that's available, and I'm sure you heard about them. The FIT test, or the fecal immunochemical test, is actually a little card that your primary doctor gives you, and it's been around for a very, very long time. Even before the colonoscopy, that's what your primary doctor used to give you as part of your routine physical. This has to be done yearly if you decide to go this route, and it looks for blood in your stool. Long time ago, we had to do a special diet. Don't eat meat, don't do this, etc., because you could get false positive results. Now the new generation of FIT tests, fecal immunochemical tests, can differentiate human blood versus meat, for example. So you don't have to be that specific for in your diet before you do the Hemocold card, but that's an option. If you do the Hemocold card instead of doing colonoscopy, you have to do it every year. And if it's positive, you do need a colonoscopy. The other question I get with the FIT test is, I got one test is positive with my primary doctor. Can I do another one and see if it's negative? Well, it doesn't matter if the second one is negative or if the third one is negative. If you have one positive test, somebody has to explain to me, where is this positive test coming from? It could be hemorrhoid, it could be colon polyp, but you only need one test to tell me to get you to the colonoscopy. The multi-target stool test DNA, that's a mouthful, but basically this is referring to Cologuard, which I'm sure you guys, all of you have heard about it on TV. This is a non-invasive way of looking for colon cancer. It checks not just for blood, but it also checks for abnormal DNA that's been associated with colon cancer and precancerous polyps. So once I order, the company sends the kit to your house, you follow the instructions, mix your stool in the kit and send it away, then I get the results saying either positive or negative. It's very good for picking up colon cancer on an average risk patients. So 92, they said even 97% of colon cancer can be picked up. The only problem with this test is that it has a 10% false positive result. So 1 in 10 people, there's nothing wrong with them, but the results will come back positive. And if that test is positive, you are going to need a colonoscopy for us to evaluate. The Cologuard, or the multi-target stool DNA, is actually only for average screening patients. No family history, no personal history of colon cancer or polyps, and certainly no symptoms. Why? Because it'll miss half of polyps. So it's great in picking up cancer, but it'll miss polyps. So you have to repeat this every 3 years. You do not get the typical 10 years you get for colonoscopy. And Medicare pays for this, and now a lot of commercial companies are paying, insurances are paying for it. Medicare pays for Cologuard up until age 84. Medicare pays for colonoscopy. There's no limit to colonoscopy. And what about those patients who, well, let's take it back. So those patients who do not want to get a colonoscopy or fit test, then Cologuard would be a better choice. But if there's something abnormal and we need to evaluate the colon, there's a thing called CT colonography or virtual colonoscopy. It's been around for a long time now, much way before the Cologuard became available. This is basically a CT scan of looking at your colon. You still have to take some kind of a prep to clean yourself out, and then you do a CT scan. So they put in 3 dimensions your colon, and it can differentiate a food particle, food stool ball versus a colon polyp. And they can tell us if there's a polyp in which part of your colon you have it. The advantage of this is that there is no sedation, so you're going to be awake when they do this. They put a little air into your rectum and insufflate your colon when they do the CAT scan. The disadvantage is that you still have to take the preps. The prep is a little bit different and it does not have to be as clean as ours, but there is a prep involved. If the CT colonography or virtual colonoscopy is normal, then you need to repeat it in 5 years because it will not pick up small polyps. Any polyps smaller than 5 millimeter, it will not be able to pick it up. Anything bigger, it will pick up. I use virtual colonoscopy on patients who are high risk for sedation or colonoscopy. So elderly patients, very bad lung disease, so high risk for sedation, cardiac causes, then certainly CT colonoscopy and virtual colonoscopy would be a better option. The other time we use virtual colonoscopy is if you have a very twisty colon. Some people's colons are very twisty because they have adhesions from previous surgery, and it's high risk for us to do the full colonoscopy, or we do it, but we can't reach the cecum. Then we complement it with the virtual colonoscopy so we can see the rest of the colon. When this first came around, insurance were not paying for them, and it was about $1,000. I heard now it's become much less expensive, maybe about $400. It's done by radiology, not by us. And most insurances require us to give a reason why we're doing it. If they do find something in virtual colonoscopy, then again, you're going to need the colonoscopy to confirm and remove those polyps that were seen on virtual colonoscopy. The colon capsule. So capsule is actually a pill. It's a size of a big vitamin pill. We have it in America for small bowel. So people who have iron deficiency, after the endoscopy and colonoscopy, we give them, we call it pill cam, a capsule to swallow. As it goes down, it takes picture. It comes out of your rectum. And you download the picture and we can look to see the source of the bleeding or any lesions. So we have it for the small bowel, we have it for the esophagus or the swallowing, especially for the patients with liver disease for variceals, esophageal varices. It's not available in US for the colon capsule that I'm aware of. I know European countries have it. And I heard that England is doing some study now using the colon capsule as a screening test. Because after COVID, I think everybody wants to do a colonoscopy now, and I think they're being overwhelmed. So they want to know whether colon capsule is a way to sort of screen them to see which patients need the full colonoscopy for us to go after those polyps. So it may be coming. This is another way of showing you what I just went through. American College of Gastroenterology is basically letting you know that the colonoscopy is a one step where we can not only detect but do something about it. We can remove the polyp and do something about it. And the rest, whether it's a Cologuard or Cologuard or virtual colonoscopy, colon capsule is not quite available in US. If it's positive, then you're going to need the second step, which is a colonoscopy. I didn't talk about the flexible sigmoidoscopy, so I'll talk a little bit now. Before colonoscopy, this would be actually even before my time, I've been doing colonoscopies for almost 20 years now. Insurance would only pay for a flexible sigmoidoscopy. So remember the picture that I showed you before, the anatomy. Flexible sigmoidoscopy goes from rectum to the sigmoid. It's about 50, 60 centimeters long. So it's not as long as the colonoscopy, but it does look the lower half of the colon. So insurances would only pay for this. So this is what they use to do colon cancer screening. And they figure, well, if there are no polyps on the left side of the colon, which is the rectum and the sigmoid, probably you will not have any polyps on the right side. So they just did this. Well, studies after studies have now shown that if you only look one side of the colon, you're going to miss those flat lesions on the right side of the colon. So since those studies came out, you don't really use flexible sigmoidoscopy. I'll tell you when I use those. Now we know that we have to look at the whole colon. Just because you looked at part of the colon, that doesn't guarantee that the other colon is going to be, other part of the colon is normal. I do use flexible sigmoidoscopy in office for patients who did have colonoscopy not that long ago, a year or two ago. They haven't had any issues, but they have rectal bleeding. The question is this a hemorrhoid bleed or patients who have colitis? They were doing very well, all of a sudden they're having bloody diarrhea. Is this colitis under control? Do I need to adjust medications? So I use the flexible sigmoidoscopy for a quick look in office to see if I need to adjust medications or do a full colonoscopy. I don't really use it as a colon cancer screening tool anymore because it cannot look at the whole colon. All right, so this is a major change for us. So remember, except for African Americans, remember, we always started at age 45. We used to do our colon cancer screening starting at age 50. In 2018, American Cancer Association, so American ACA, have lowered their colon cancer recommendation age from 50 to 45. Remember early on I told you about the higher risk of colon and colorectal cancer in younger patients, born in 1990 and younger. This month, March of 2021, American College of Gastroenterology also recommended starting at age 45. So now the current recommendation is to screen average risk individuals between ages 45 and 75 to look for those polyps and remove those polyps called adenomas and therefore reduce the colon cancer. Now, what about patients 75 and older? I have a lot of patients who live till 90 some, 100 some, and they want to know, when do I stop doing my colonoscopy? When I first started doing colonoscopies, the age was 75. So at age 75, we would tell them, you've had enough colonoscopies. If you're doing well and if you have no symptoms, you can probably stop doing colonoscopy. Unless you have symptoms, then you come and talk to me. Well, then they changed it 75 because our patients are living much longer and much healthier lives. So now the current recommendation is between age 75 and 85. If we, the doctors, feel that you're going to live another 7 to 10 years, we are supposed to offer it to you. Now, close to 80 is when I sort of start having this conversation. You always have to weigh the risks and benefits. It's a very safe procedure. I've done it in 90-year-old patients if they have symptoms, bleeding, anemia, etc., and they do very, very well. But the question is, anything we do has its benefits and its risks. And the risks, which I didn't talk about yet, I'll talk about that in a little bit. And if you're very healthy and we think you're going to live another 10 years, close to age 80 is when I sort of say, well, after this, unless you have any symptoms, if you don't have any symptoms, we probably will not do a screening test. So it's very personalized and individualized depending on your medical problems. So American Cancer Society is recommending the colonoscopy. The Hemocol card, we don't use it as often. That is what's recommended. The other screening test, the Cologuard, is the most popular one because it's non-invasive. You have to understand that it does not pick up polyps that well, maybe half. So you do need to repeat it every 3 years if you go that route. The the Cologuard is really for average risk patients. The other question I get is, I had polyps before on the last colonoscopy, can I do Cologuard now? The answer is you really should not, because it will not pick up the polyps. I only had one case where the Cologuard was negative. That patient refused to do colonoscopy. I could not convince her. The Cologuard was negative, but the next year she had rectal bleeding on a colonoscopy, we found colon cancer. So it's not 100% foolproof, but it is available for those patients who refuse to get colonoscopy. The colonoscopy also has its own, it's not 100% either. There's a miss rate. They range between 6%, some have some reports even say 20-some%. So anything that we have, whether it's a CT colonography, Cologuard, colonoscopy, nothing is 100%. But if we find it, we can prevent colon cancer. So the current recommendation is starting at age 45, colonoscopy, and if it's normal, every 10 years. If you refuse to do colonoscopy, you can do the hemocol card with a primary doctor looking for blood every year. If other alternatives are used for average risk patients, then that's the Cologuard or the multi-target stool DNA every 3 years. Flexible sigmoidoscopy, although it's still in our list of possible alternatives, we don't really use it that often. We have a flexible sigmoidoscopy. I don't think there are too many GI doctors that still have the sigmoidoscopy. The CT colonography or the virtual colonoscopy every 5 years. Remember, I told you it cannot pick up small polyps less than 5 millimeters. That's why it's 5 years and not 10 years. This is done by radiologists. It is very reader dependent, so the radiologists have to be familiar and comfortable reading the colon and the colon capsule if it's available every 5 years. There's a blood work called Septin-9. It's been around for some time now, not that long, but at least for a couple of years now. It is not very sensitive or specific. That's why the recommendation is against it. Let's see. So African Americans, remember we talked about starting younger at age 45, as it's always been. And the recommendation of starting at age 45. If you have a family history of colon cancer or personal history of colon polyps, your surveillance colonoscopy is no longer 10 years. We have to bring you back 5 years. If not earlier, there's certain genetic predisposition, patients with genetic predisposition that we have to do 1 to 2 years, depending on what it is. I think that's my talk here. I actually did not talk much about the bowel prep. I'd be happy to, if there are any questions, anybody has any question about bowel prep, I can talk about that. Or if anybody wants me to go over the overview of what to expect on the day of colonoscopy, I can do that as well.
So we definitely do have some questions, Dr. Wu. So you actually ended with a great segue because that actually goes into one of the questions that we have regarding bowel prep. So I'm going to start with the first question that I got from one of our patients. She states that she had a colonoscopy over a year ago and she's still having loose stools. Prior to the procedure, they were 4 on the Bristol scale, now improved to 6 after probiotics. She was at 7 after the procedure. So she's wondering, is this mainly a function of the prep? One is, I guess it was one that she had never used before. This was the first time she'd had such a severe reaction after having this procedure for 6 years over the last 6 procedures over the last 25 years.
So the colonoscopy prep, so I'll tie in the colonoscopy prep and then and answer her question. So the colonoscopy prep have come a long way. We used to give a gallon of salty water called Go Lightly, and then we called it Half Lightly, and then we had movie prep, we had all pill from Osmo prep. So we're getting better, but no matter what we give you, the result is the same. We've got to clean you out. The ones that we use more often now is called Suprep, which is 16 ounces of liquid medicine, followed by 2 16 ounces of anything we like to drink, so clear liquid of your choice. And the easiest one I have is called Clempic, which is only 5 ounces. The cranberry one tastes like cranberry juice, followed by 5 glasses. And long time ago, even during my training, we used to do the prep all the night before. You do it the night before and you're done. New studies, however, are showing that you have to split them. So all standard now is doing it the night before around 5 o'clock when you're on a clear liquid diet and repeating again the same prep 5 hours before your scheduled colonoscopy. And your stool color should be clear yellow, almost as if urine color clear. Otherwise, we can't see the tiny polyps. We now also have a Suprep called Sutap that comes as a tablet form as well. So we are getting better. But like I said, the result is the same. So most patients will have diarrhea, usually within the first 3 hours. Patients who are very constipated or They didn't realize they were constipated, but they had a lot in their colon. I've seen patients, nothing works. At 2 o'clock in the morning, eventually floodgates open up and they have diarrhea. So when the PrEP work sort of ranges. After the colonoscopy, remember during colonoscopy, we suction out and flush out, so there really should not be anything there. Your diarrhea should be gone. So maybe some patients may have diarrhea even the day of, maybe even the day after, but the medicine should not last a year. So if you're telling me you had a colonoscopy a year ago and your diarrhea is continuing, there has to be some workup for the what we now call chronic diarrhea. If you were having loose stools to begin with, one of the works of colonoscopy, not just colon cancer screening, one of the things that we do colonoscopy for is diarrhea. So if people have loose stools, stool test is normal, the celiac blood work is normal, it's not lactose intolerance, it's not bacterial overgrowth in your small bowel, then we actually do a random biopsy of a normal looking colon, looking for what's called a microscopic colitis. It's an autoimmune disease where all the stool tests and blood work is normal. The colon looks completely normal during colonoscopy, but if you look under the microscope, pathologists can tell me that there's a microscopic, so inflammation, colitis, it's an autoimmune disease, and they can present, those patients can present with diarrhea, waxing and waning diarrhea. So the workup for what you have now as a chronic diarrhea is very long, depending on whether you're losing weight, whether it's related to eating or not, whether it's waking up in the middle of the night. Pancreatic insufficiency can also present with diarrhea, so that has to be worked up. But I don't think it's the colonoscopy PrEP. Like you said, you had 4 or 6 before, colonoscopies before, so it's unlikely that the PrEP that you took a year ago is causing your severe diarrhea now.
So we have another question about colonoscopy prep. This one is asking if you could talk about, and I've never heard of this prep, Dr. Wu, so I'm not sure if I'm pronouncing it correctly, Hygia Care as a colonoscopy prep option.
Yeah. So that's actually sort of new. We don't have it in our practice. The Hygia Care, the large capital digestive group, CDC group has it. And the way they do it, and I haven't done it myself, so I can't really tell you the details of it, is for patients who are very constipated. So remember, we have a standard PrEP for average screening colonoscopy patients who are not constipated. One of the reasons why we see patients in the office or virtually before your colonoscopy is to try to gauge, is an average PrEP adequate for you to clean out? So for example, if I give you a Suprep, do I think that it's going to clean you out? How do I know? Part of it is dependent on your history. If you tell me you're having pellet-like stools, I go every 3 days, most likely I need to work on your bowel regimen before I even start you on the colonoscopy PrEP. Otherwise, you're not going to be clean. If you're on certain medications that slow down your colon, then I probably need to work a little bit more or get you started a little bit earlier. Certain medical issues, diabetes, for or Ehlers-Danlos. So there's certain medical issues that also slow down your gut. So we are also gauging to see, is the standard PrEP adequate, or do I need to give you more? The I forget the name, what was it called? Hydroclea, what was it called? Korea?
Hygia Care.
Oh, that's right, Hygia Care. So this is sort of new to me. I got a message from the Capital Digestive Group, which is a big GI group. We all sort of work together, asking me whether I would refer patients to use that. And I've seen that they've used it even before colonoscopy, or even when they're not doing colonoscopy. And what they're doing is they're basically cleaning you out. They're putting some water in there into your rectum. Remember, the colon is a long tool, so you're going from the rectum, putting some water in, and then cleaning it out. And I think the initial idea was to use it to clean it out. So in case you didn't clean out enough for the colonoscopy, then they have that machine there. Maybe they can use a little bit extra cleaning. That way you don't have to come back another time to do the colonoscopy. But I also heard that they're doing it as a, not necessarily for prior to colonoscopy, but for patients who are constipated and they just, nothing else seems to be working and they just want to sort of clean out. So if I don't think insurance covers, they told me you have to pay out of cash, 150 or 200, I forget exactly how much, but you have to pay out of cash. I don't think all centers do it. The CDC, is it a Rockville or Shady Grove? One of the center does it. That's where their machine is. And once you clean out, I guess the only problem is, remember, anytime you eat, you are going to get more stool. So you can clean out once, and it's fine if you do it for the colonoscopy. But if you keep on eating, which we all have to do, you are going to reaccumulate again. And then the question becomes, well, how often do you do this if this is only a temporary solution? But yes, I do have some patients ask me about it. I think I've only sent one patient because just nothing was working.
So our next question asks, how do you know if a person has a very quote unquote twisty colon, such as that might result with adhesions from prior surgery or adhesions?
Yeah. So that's a very good question, because for us, when we go over your medical history, surgical history, the other things we look for are patients who are going to be a little bit tougher for us to do colonoscopy, meaning if you had a surgery, typically bowel surgery, you can have adhesions when it heals. So remember the anatomy that I drew for you. Let's see, well, I can't go in that way. Let me see if I can find that anatomy, and then I'll be able to. Okay, so this is good enough. So there are certain parts of the colon that are fixed, and there's certain parts of the colon that are flexible. So think of it like a long hose, water hose. Ascending, descending, and rectum are fixed. So when you put air or water in, they will not twist around. Sigmoid colon, this part is called sigmoid colon. And by the way, that's how far the sigmoidoscopy goes. Sigmoid colon, transverse colon, and the cecum are not fixed, which means they can flip back and forth. So when you put air or when the stool is coming out, it allows you to right itself. So it could have twisted, but it can untwist itself because it's flexible. Once you have surgery, the parts of the colon that used to be very flexible can now be sort of stuck next to each other and cause what we call adhesions. Usually it would not be an issue, except sometimes you can have a partial obstruction. You'll know it because you'll be so distended in pain. Sometimes you have to go to the ER. Or for us, when we start putting air inside as we do the colonoscopy, now the tube is filling and it can cause a little twist. Any other time, you might untwist itself on its own. But with people with adhesions, you have a limited movement. And we can feel it as a tight turn, for example, especially in the sigmoid colon, or as we go around these turns, and there are many turns we have to go through, we sort of have hard time reaching the cecum, or we notice that as we're pushing, the colon is very, very long, meaning the longer we are, the more air we put in, so it becomes elongated. So we call those colons either tortuous, redundant. There are many terms that we use. So when I speak with the patient in the office, we can't really tell what kind of colon you have. Yes, if you had a surgery, there's a chance that you may have adhesions, but not everybody has adhesions. Constipation, yes, you could have a long colon, but we have patients whose colon is not that long, but they're constipated for other reasons, medications, not enough water, etc. But during colonoscopy, we can feel it. So as we're going, we can feel the tight turns, and there are a lot of twisty, long turns. Most of the time, we are very limited on the length of the scope, and sometimes we sort of run out of scope. We have different maneuvers that we can do to get to the cecum, but that's how we know. And usually when you wake up, if it's pretty severe, we tell you had a very twisty or tortuous colon, and sometimes we write it on the report to remind me next time I go in that this person has a twisty colon, because we have certain maneuvers that we can do even before we get started to prevent that colon becoming more insufflated, elongated, and twisted. I always use a pediatric scope. We have an adult scope and a pediatric scope. The length is the same, but the pediatric scope is thinner. And I do a lot of female colonoscopies, women colonoscopies, because I guess women prefer women to do it. In women, I don't know why, but we have a lot of organs down there. Not only do we have the colon, we have the bladder, the uterus, the ovaries. So we have a little twisty sigmoid colon, but the pediatric scope, it's because it's so much flexible and thinner, allows us to get around the turns much, much easier. So the standard that I use is a pediatric scope. Did I answer that question? I know I sort of went off tangent too.
No, I believe that you did. We have several more questions. I have one that asks about if an IV is required for virtual colonoscopy, and are there alternatives to the IV for a regular colonoscopy?
By IV, are they talking about the IV hydration?
Most likely, I believe so.
Yeah. So the virtual colonoscopy, I do not do them, so I can't really comment too much on that one. For the conventional colonoscopy that we do, there are couple reasons why we put the IV. One is because through the IV, so let me backtrack. So is the IV really required, or can you get away without doing it? Let's put it that way. So we do have patients, I have patients, and I just did one last week, who do not want any sedation. So they went through the prep, they do not want to be sedated, they want to be awake and they want to watch. So the first question they ask is, do I have to have an IV if no one's going to give me medication anyway? And I say yes for two reasons. One is you're very dehydrated from all the prep that you went through. So we hydrate you through the IV. So that's the first thing we do. So make sure your blood pressure is okay and hydrate you. The second thing is, even without, it's very rare, but when we do the colonoscopy, there are risks associated with it. Remember, your electrolytes are a little bit off because you've been through a major diarrhea. And we monitor you on the monitor, your heart rate, your rhythm, your breathing, etc. In case something happens, the IV gives us a quick access so we can do something about it. So the last thing you want is for us to be doing procedure, any procedure, and something goes bad, and that's not the time to be trying to put IVs in. So that IV is there so we can help you, we can do something about it quickly if something happens. So in colonoscopy, yes, the IV, we do recommend IV, and even without sedation, I do recommend IV because it gives you access to your blood vessel, not because we need it for the colonoscopy, but for that reason.
Awesome. Thank you. We have another question, um, basically wondering if you recommend the test over the Cologuard.
Do I recommend the FIT test over the Cologuard? Yeah, so I assume the patient who's asking is an average risk, has no family history, no personal history, no symptoms, but the doctor, your primary doctor is saying, can you do, it's time for your colonoscopy, right? Yeah. So I know the American Cancer College of Gastroenterology is recommending a FIT test. I actually do not use the FIT test that much. Usually you either do the Cologuard, or if you're refusing to do the Cologuard, then I usually order, I'm sorry, you do a colonoscopy, sorry, but if you're refusing to do colonoscopy, I usually end up ordering Cologuard. One, because 1 year goes by very, very fast. The FIT, you have to do it every year. And I don't know too many patients, first of all, they don't go see their primary doctor that often, especially if you're healthy. So it's very unlikely I'm going to catch them with the FIT test every year. The Cologuard, not only does it look for blood, it also does look for DNA tests, so that there are a few other ways of catching those patients that need to be screened. And most insurances now should be paying for it if you're average risk. Colonoscopy still is the best way to do it because you can remove, not just look for it, but you can remove it. But if that patient is absolutely refusing, I am not going to do colonoscopy, I have to say, despite the fact that American College of Gastroenterology is recommending FIT tests, I usually end up ordering a Cologuard because it gives me at least 3 years, it gives the patient at least 3 years.
Okay, great. And I'm going to skip over one question because you're kind of talking about that one of the other questions that's a little bit later. Can you tell us what average risk means?
Well, average risk means you have no family history. None of your family members have any colon cancer, colon polyps. You just turned 45 and you're coming to see your primary doctor as a routine physical exam, but nothing bothers you. You have no stomach pain, your bowel movement is normal, you have no weight loss, your physical labs are completely normal, you're not anemic. And literally, you would not come and see me as a GI doctor unless your primary doctor pushed you towards me. That's what I consider average risk.
The other question that I skipped over was, it sounds like colonoscopy is the gold standard for testing. Are you doing colonoscopies in
Am I doing colonoscopy in?
the office? I
Oh,
guess in Rockville Internal Medicine Group.
yes. So let me actually let me go back to that last question and let me come back. So you were talking about what's average risk. The one thing I notice with my patients, because I'm also aging with my own patients. So when I'm younger and my patients are healthy 50 years old, or at that time it was 50, now it's 45, their siblings and their family members also are much younger. So sometimes, although they tell me they have no family history, as time goes on, and at that time it was normal, we give them 10 years, as time goes on, well, their brother got a colonoscopy and found out they have a polyp, or their mother was just diagnosed with colon cancer. So although you may be average risk now when you're 45 years old, that may change as your family members also get their screening and as they age as well. So you also have to keep that in mind nowadays it's easier. Back then people did not talk about colonoscopies and their poops, etc. Now I think people are much more open about colon cancer screening. So keep that in mind when your colonoscopy is normal, when you have a family gathering. And that's why when I find polyp in my patients, I always tell them, make sure you let your first 3 relatives know that we found polyp in you. Their risk is now much higher. Instead of doing it every 10 years, they need to do it every 5 years. So yes, so since COVID, so last year when COVID hit us, we shut everything down because at that time we knew that COVID was also transmitted through stool. Since then, at that time, we've been only doing emergency cases. Since then, starting July, we now started doing elective procedures. And to be cautious, all doctors and staff, even now, we are tested every 2 weeks for COVID to make sure we are negative. All the doctors are vaccinated. Almost all of the staff is now vaccinated. All the patients also who come to the endo center have to be vaccinated. Have to be tested for COVID 2 days before the procedure. So that's the standard. So any procedure now triggers a COVID testing. Now a lot more patients are getting their vaccine, so that may change. The vaccine does not completely protect you, as you know. You can still get COVID, your symptoms will not be as severe, but because we have so many other patients who have not had a chance to vaccinate, we are still following that same protocol just so that we protect everybody. So yes, we are doing colonoscopies. We do them at the endo center, Bethesda Endo Center off of Democracy. We do have flexible sigmoidoscopy in office without sedation. We also do unsedated endoscopy in office. You still have to be tested for COVID. The advantage of the unsedated ones is if I need it, someone's bleeding and I need to know what's going on, I can quickly bring you to the endo, to my office and do it. Anything we do in the office, at Rockville office, we do not sedate you. You're going to be awake, you can actually watch it. In the endoscopy, we go through the nose. This is very much like the ear, nose, and throat doctor when they go in through the nose to look for hoarseness and vocal issues. It's the same thing, but now we actually go much lower. We actually go much lower to the stomach. So we reserve the unsedated EGD for patients who do not want to be sedated or who are high risk for sedation, or they are bleeding black stool. It's Friday afternoon. They don't want to go to the ER. I need to take a look. Is this someone I have to still send them to ER, or is this an ulcer that I can treat as an outpatient? Or food getting stuck there, they can't swallow, then we use it for emergency procedures. Otherwise, all patients, especially elective procedures like colonoscopy, including endoscopy, we do it at the endo center with sedation. We work with the anesthesiology team. We have anesthesiologists and nurse anesthetists, and they use that IV. Remember, somebody was asking about the IV. Not only do we hydrate you, but the anesthesiologists use a medicine called propofol to sort of, knock you out. So you take a nice sleep for about 20 minutes. This is not general anesthesia. They will not intubate you or paralyze you. You're breathing on your own. And that medicine has a very short half-life. It looks like milk. It goes quickly, and within a few seconds, you fall asleep. And as soon as they see me reach the cecum, they start lightening up. So by the time I'm done with the procedure, most patients are awake. It makes you feel like you just came out of a spa. So it's a very wonderful medication. I just had my colonoscopy, so I can tell you it feels wonderful. And the cleaning out wasn't that bad either, actually. I heard so many patients complaining about the prep. I was expecting I would be having a lot of problem, but as long as you follow the instructions and as long as you drink lots of water, actually it feels good to really clean yourself out too. Probably like the hygiene care that people are looking forward to. That's a similar idea, but we're not putting anything in your butt. We're just giving it through your mouth.
I can attest to the use of the propofol. I had my EGD back in I think it was December. I had to have an EGD, and I was terrified because I did not want to have an EGD. Like the thought process that something be stuck by my throat, and it was hilarious because they gave me the medication and then they told me to count backwards, and I don't even think I made it past 98. And then the next thing I woke up, I was giggling and seeing smooth operator. So it's a very surreal experience. The next question that we have, I think this is probably going to be maybe our last question, is can polyps or colon cancer occur in the small intestine? And if so, how does one screen for that?
So we have a screening for colon cancer because of the risk is higher. In Asia, in certain parts of the country, Eastern Europe, South and Central America, there's a higher risk for stomach cancer associated with H. pylori. So there is a screening protocol, not in America, but there is screening protocol in those countries, including Japan and Korea, where they do screening, a lot of screening for the endoscopy. Small bowel is the one area, one part of the GI tract that does not have that many cancers. So small bowel is extremely long. So there's no such thing as a screening for polyps. You can still get polyps in the small bowel. In the in the small bowel, we usually see lymphomas. Those are the carcinoids. Those are the ones that we see in the small bowel. Yes, you can still have adenomas, just like the colon adenomas. There's certain genetic, like Lynch syndrome, familial adenomatous polyposis. Those patients are a higher risk for getting small bowel cancer. But in a general population, average population, we do not do any screening of the small bowel. Having said that, if you have symptoms, we do. So if you have iron deficiency anemia, endoscopy and colonoscopy doesn't show anything, then we look at the small bowel. And remember the colon pill we talked about, that it looks like a vitamin pill with a video camera at the end? Well, although we don't have that availability to look at the colon, we do have the pills to look at the small bowel. It's been around for a long time. So then you swallow the pill and it has a video camera. It takes pictures as it goes down. You wear a little belt and eventually it comes out of your poo. You don't have to go retrieve it, but it sends all these messages. So we get picture after picture of your small bowel that we can look for polyps. There are radiologic way of doing it called MR enterography or CT enterography. It's like a CAT scan or MRI, but it specializes in the small bowel, looking for lumps or polyps or lesions. And if either one finds something, then there's what we call either a push enteroscopy, which is very much like a endoscopy with a longer scope. So now not only do you look at the stomach, but you go past into your small bowel, or what's called a balloon enteroscopy. Again, it's like a colonoscopy, but much longer. And think of the small bowel like a sausage. You need to get through it, but because it's so long, you need some way to sort of get through that area. So the balloon enteroscopy is a technique where they insufflate the balloon inside the small bowel, and it sort of starts moving forward. So we do have ways of doing it. We don't have small bowel screening tests, as you call it, though, unless you have symptoms. So if you have symptoms, yes, we have ways to look at it, but we don't do a screening small bowel evaluation.
Okay, so I want to say thank you so much to everyone who participated. I think that there were still a few questions that I was not able to get to, but I want to be respectful of everyone's time and definitely don't want to have Dr. Wu starting late and having patients get mad at her. But I did want to take an opportunity because Lori Shell did pop on. However, we had so many questions, we weren't able to kind of get to her part of the talk. So I think it's still a very worthwhile information that she has. So she's available if you want to reach out to her to answer any nutritional questions that you might have. regarding, kind of nutritional concerns regarding colonoscopy preps and colon cancer. And I'll ask her to unmute briefly and just say hello. But I think that it would probably be a good idea if I can figure out a way for us to maybe have a nutritional segment. Maybe I won't be able to arrange it this month, but maybe I can do it in April, even though it won't be for colon cancer, but it'll be about colon cancer, just so that way you can get that nutritional information to help you keep your colon as healthy as possible. Lori, are you still there? Is she there? Uh-oh. Maybe she had to leave. Uh-oh. Okay. Oh, okay, so somebody would like to attend a segment on nutrition. Okay, so I will definitely, oh, I have to unmute her. Oh, Lord have mercy. I don't know how I got elected that job. So let me see how to unmute her. But since it does seem like there is definitely interest uh, in the nutritional segment, I will definitely make sure there she is. I don't know how to unmute you, dear heart. I'm trying. I'm trying. Uh, Lori, I swear I'm trying. Um, I will definitely make sure that I arrange that, because for some reason I don't know. Again, this is my first time, so you guys have to bear with me on how to get her unmuted. But I will definitely make sure that I get with her to arrange that. And I'm so sorry, Lori, that I can't unmute you. I feel horrible. So I think that's all. And just thank you again for participating with us. And you guys have a great week, and stay tuned to your patient portal and emails for when that nutritional segment and when our next segment is going to be coming out in April. Is Lori there? Did we get her muted? No. All righty then. Have a great week, you guys. Thanks, Dr. Wu.
Thank you, Maria. Thank you.